Okay, so hitting the home stretch, and really a pleasure to introduce Dr. Stephanie Aghamoosa. Hopefully, I didn't butcher that too well. Thank you. Who I've gotten to know a little bit, who's at the Medical University of South Carolina. And if we think about some of the institutions that are really world renowned for brain stimulation, MUSC is one of them. And so thank you, Stephanie, for coming up. I know there were some flight delays yesterday. We're happy to have you. Is really doing some fantastic work with theta burst stimulation. So I'm going to hand it over.
Thanks so much for having me, and I hope everyone's awake and with me. There's two more amazing speakers to cap off the fantastic speakers we've heard so far today. So thank you again. I'm going to tell you today about our ongoing work in investigating intermittent theta burst stimulation, a form of RTMS, as a treatment for cognition in people with mild cognitive impairment. So first, I want to just take a step back and think clinically about the continuum of function in Alzheimer's disease. So that ranges all the way from the preclinical disease stage, where people are asymptomatic but may have AD-related pathology already accumulating in the brain, all the way to dementia, where people have cognitive and behavioral impairments that interfere with their ability to function independently. And so it's a wide range. And what I'm going to focus on today is the pre-dementia stage called MCI, mild cognitive impairment, where people are experiencing cognitive changes but remain functionally intact. So why do I care about people with MCI as a clinician? Well, nearly 20% of older adults in the US are estimated to have MCI, and every 5 years, a third of those will go on to develop dementia. So this MCI stage is a really important opportunity for what we call secondary prevention. So that is preventing progression to dementia or just slowing progression to dementia. And that's because an intervention that could delay dementia by 5 years could decrease dementia prevalence by 40% and healthcare costs by 30%, so to the tune of $179 billion in a 10-year span. So if we can find ways to slow progression to dementia, that would make a huge public health impact. Now, we all know probably that disease-modifying medications for Alzheimer's disease are now on the market, which is exciting. However, these medications have really strict criteria that may bar over 90% of people with MCI from receiving that treatment right now, due to just kind of the clinical picture that they need to show. And so I believe that non-pharmacologic interventions like non-invasive brain stimulation represent a really promising complementary or alternative treatment that would be more widely applicable to people with MCI, so we could help a larger number of patients. So hopefully I've convinced you that this is an important, subgroup to look at, and why we're interested in theta burst. So we've heard a lot about TMS today. I'm not going to go into detail since we already sort of know, but you have that graphic there. I just want to draw a distinction between RTMS and theta burst that I'll be talking today. So theta burst stimulation is a subtype of RTMS that, rather than TMS, which delivers pulses, let's say at 10 hertz, so 10 pulses per second, theta burst actually delivers triplets, so very fast triplets of pulses in bursts. And this allows a higher frequency pulse pattern, so for example, 50 hertz, that allows us to substantially shorten stimulation sessions and deliver treatments that may, traditionally, for example, our TMS for depression is 5 days a week for 4 to 6 weeks. You can deliver the same amount of treatment in as few as 3 to 5 days, a couple hours on each of those days. So again, when thinking about treating patients, this is a lot more clinically scalable, potentially more feasible, doable for older adults who have cognitive impairment, who might not tolerate or logistically be able to engage in a long treatment. So that's why we're interested in theta burst. Now, there is an accumulating evidence that TMS in general is beneficial for cognition in people with MCI or Alzheimer's disease dementia. This is the result of a meta-analysis of MCI and AD studies that found a medium-large overall effect on cognition, an effect that was actually slightly larger in studies of MCI than it was in those with dementia. And across these studies, a fair number of sites have been targeted with TMS, cortical targets, and this meta-analysis actually found strongest evidence for left dorsolateral prefrontal cortex stimulation in this group. And so that is our target area. The left DLPSC is highly implicated in cognition, so things like processing speed, executive function, and secondarily beneficial for memory processes. Now, despite this growing evidence base for TMS, when we got interested in theta bursts, there had actually been no published studies of theta burst stimulation in people with MCI or Alzheimer's disease. That has since changed. There are a few out now, but we needed to, if we're going to do this treatment, we needed to first establish that this treatment was safe, tolerable, feasible in people with MCI, because we're talking about brains with neuropathology. And so we conducted, this is my previous postdoc mentor, Anya Benitez. She was the lead of this pilot study it was a phase 1 trial of TBS for MCI. So quickly, we found people with clinical diagnoses of MCI. We conducted pre and post-treatment assessments that involved clinical assessments, neuropsychological testing, and brain MRI. And then we administered 3 days of theta burst treatment. Each day was 8 3-minute stimulation sessions. I will note that people did do some computerized cognitive training in the breaks between stimulation sessions. This was extremely low dosed and only to determine feasibility. So I won't be talking about that much today. We also had a 4-week follow-up period that I also won't be talking about today, where people could do some cognitive training at home. Now, we recruited 24 patients with amnestic mild cognitive impairment, presumably due to Alzheimer's disease. So we didn't have biomarker confirmation, but this was the clinical decision based on neurology and neuropsychology. They were older, pretty well educated, college educated, about 50% female, predominantly white sample. This is who comes through our clinic. Here are the neuropsych cognitive scores for our sample at baseline testing in our study. I show you this, if you just look along the x-axis there, I've lumped the tests by cognitive domain. I show you this just to show you that they were in fact quite amnestic when they came into the study, but also had some speed executive function impairments. So our results, we had 24 people enroll, we had 22 people initiate treatment, and 21 completed all procedures for the study. So that's a really great retention rate. Only one person dropped out, and it actually wasn't even due to the treatment. It was for personal reasons. We had no serious adverse events, no seizures, no neuropsychiatric changes that you might be concerned about, like suicidality or hypomania or mania. We had no clinically significant neuroradiological changes. Again, in diseased brains, there's some concern that could occur. We also found no decrements in global cognition. So we used a very sort of brief cognitive screener, again, just to make sure there wasn't some sort of adverse, unexpected decline that people experienced. So this is the MoCA, pre and post. Now, another aspect of safety that has actually been touched upon today by a very astute question is that in people with neurodegenerative diseases, you have atrophy. Now, this causes CSF redistribution, as you can see, which can actually either attenuate or amplify the stimulation as it passes through. And so we need to make sure that the amount of stimulation that was reaching cortex was in a safe and potentially therapeutic range. To do this, we used E-field modeling, which you've seen several times today. And we did, in fact, find that every participant received what is considered to be a safe level of stimulation at the left DLPSC. Now, in terms of tolerability, acceptability, we took a really granular approach. We conducted these momentary assessments of symptoms. And so let me orient you a little bit. We have in the left, the yellow encased, these are ratings of what the person experienced during active treatment. And so, for example, this is headaches. And then for each of the 3 treatment days, after each of the 8 stimulation sessions, they told us, did you have any headache during the active stimulation? Then in the blue, they were asked, okay, do you have any headache right now? Right? So while you were being stimulated and right now. Now, what did we see here? You can barely tell, but actually at the bottom are all box plots. So you can see that the modal rating for headaches is 0. And so even though some people did experience some headache, most people did not. And you can see that even though the ratings were a little higher during the actual stimulation, they went down after stimulation ceased, which is what we want to see. Now, this is small, I recognize, but these are 5 other common side effects of TMS that we did the same thing for. And the gestalt that I want you to take away is just that, again, modal ratings for every symptom were 0. And even though some people experienced symptoms, they all resolved after stimulation ceased. So highly tolerable treatment for our patients. We also gathered just sort of general acceptability. You can see here that our patients were highly motivated to attend sessions. They were interested. At the end, they were open to future treatment with TBS. They had very little desire to quit treatment and found treatment only very mildly tiring. So we were really pleased. Anecdotally, several participants were like, I would love to do this again. So very positive response to treatment. Now for preliminary efficacy. Again, this is an open label trial. We had no randomization and therefore no blinding. So take that, as what it is with these data. I wanted to show you depression just because TMS is indicated for depression. Our sample was not depressed at all at baseline. We did not recruit for that. So we saw no change in depression as you would expect. For cognition, though, we found a significant large effect size improvement on a composite measure that captures processing speed, attention, and executive function. This is a computer adaptive cognitive measure. This was, like I said, a large effect size improvement. Nearly everybody improved, and most people improved to a greater extent than you would expect based on just repeat testing, as documented in the literature. We were excited by this, and we were also further excited because we had a parallel study going on in MCI post-stroke, where we saw an equivalently large effect in the same direction. And so we were really excited about this and have parlayed this into now an R01 that we're running that I'll mention in my conclusions. Just a note about sort of an aspect of this study that I've taken the lead on. So I have funding from the Alzheimer's Association to investigate the neural mechanisms of this effect using fMRI. So just to orient you, if you think about the brain being sort of organized into distributed functional networks, we are targeting the left DLPFC, which is a primary hub of the frontoparietal brain network. And so I wanted to look at, okay, are there changes in the left DLPFC connectivity that relate to the improvement in cognition that we see? I chose to use a graph theory metric of connectivity called participation coefficient. This is the measure of how much a region is a hub, how much it participates in other networks. So you'll see that frontoparietal node that I've highlighted here has high participation coefficient. It's more of a hub. This dorsal one, for example, has low. And so I looked at participation coefficient for the left DLPFC ROI, as well as a region in V1 where we wouldn't expect to see a change. That's sort of our negative control. And what you see there in orange is that the increase in participation coefficient or hubness of that stimulated region relates to the amount of cognitive improvement, suggesting that we are, in fact, inducing increased in functional connectivity that may be supporting cognition in our patients with MCI. Okay, so next steps, just to close out, there's much work obviously needed to optimize ITBS treatment for MCI. Where do we stimulate? How do we stimulate? What is our outcome and who? We know that MCI can be due to AD, but also other things. Often there's mixed pathology. So there's a lot to explore there. We're actively working on identifying the optimal dose for symptom remediation. So this is an R01 on which I'm a co-investigator led by Anya Benitez as PI, where we are randomizing people to dose and seeing at what dose do we see cognitive improvement. And in this study, we do also have people with comorbid depression. So we can look at optimal dose for cognition and for depression. Something I'm really passionate about, as I have a background in health psychology, is combining ITBS with cognitive training for MCI. I've submitted a K23 that's focused on that. And just to close out, I want to extend my deepest gratitude to our research participants, all of my collaborators at NUSC, and our funding sources. So thank you.
Fantastic. Okay, questions?
It's well established that MCI and ABS contempt controls, they have higher data.
Yeah, so the question is, people with MCI and Alzheimer's disease have higher theta oscillations, and that this is potentially not beneficial, but yet we're stimulating with theta burst stimulation. This is an excellent question, an active area. I think that TMS EEG concurrent will answer this question. I think it's a very open question. Part of this sort of list of open questions that we have. What is the optimal pulse pattern? To Dr. Niche's presentation, how do we think more broadly in the brain about oscillation and how does that map to cognitive improvement? Absolutely, wonderful question.
So we don't know if you actually increase the data.
Yeah, we do not yet know if we are increasing theta oscillations. Yes, we do not know. Yes, definitely an area for exploration. Thank you.
Thank you.